This is the session on prevention in health for the healthcare system. I will apologize ahead of time. I have to leave about 2 o'clock to catch a plane, and Elsie has kindly agreed to represent all of the views of the group. And I hope you'll give her your support in making sure that she gets everything that you wish to have represented when it goes back into plenary. As neither Elsie nor I quite understand why we've been asked to chair this thing. So we rely on you folks to help a little bit. We've been given the objective to look at strategies for prevention in different settings, and the one that we're supposed to be looking at is prevention in healthcare. And one of the questions that perhaps we could start this off with, unless you folks have a specific direction you want to go, would be to look at what populations elder abuse prevention efforts should be aimed at within the healthcare setting, and who are the potential implementers. So the healthcare setting is obviously different from the communities in which we all come from, but I suspect that there are commonalities and commonalities of personnel. And perhaps we could start off by looking at what populations within the healthcare setting we may be able to do something in terms of prevention with. That's ending a sentence with a preposition. You're not supposed to, but we'll ignore that.
Can I ask one question?
Absolutely.
Do you think that one way we might get at that, because I was very, very taken by your comment about screening versus case finding.
Mm-hmm.
So no matter what setting we're in, we all have to get a sense of whether we're screening or case finding. Could you say a couple words about that as we then think about locality, which I think is what you're talking about? Because I think you're about to move into nursing home versus hospital versus clinic. Is that what you were talking about?
I am, yes.
So maybe just a couple of words more on case finding versus screening.
Screening is, well, I'm a little reluctant to get into that because that gets into the area of detection, and we're supposed to be looking at efforts that are aimed at prevention. So that if we start worrying about identification, I think we may be going off on a tangent, although, Terry...
That could be. I was thinking about the screening. Usually when you screen people, most of the people you screen are negatives, right?
Correct.
So that's a way to then keep them negative by preventing something. That was where my thinking was going, but I'm happy to back off.
Okay. I was thinking, as the questions were given to us as suggested questions, they're at a more global level, at a more systems level, as I understand it. And then once we've been able to deal with the systems issues, if we can, and by the way, we have a scribe here who I've not... A scribe is, oh, there's a scribe, sorry. Okay. Who's going to keep notes on this. So I was thinking more in terms of at a systems level, where interventions could be made. So as you were talking about different types of institutions, maybe somebody would like to pick an institutional setting and think about situations in which prevention may be possible, and and maybe define what that prevention might be within that setting. Jim?
Given that I have to leave in a short while, I'd like to make a pitch again for appropriate care, end-of-life care for older adults in a hospital setting. And I mean, that would require developing standards of care for older adults in that setting. And without being redundant, I'm really concerned about the final event in somebody's life being subjected to futile, excessive, and painful care.
If you were taking your institution, where would you start the process? Would you be starting it at the level of physicians? Would you be starting at the level of nurses? Would this be as part of a training experience for whoever trained through your hospital?
Probably all of the above. The problem, or a barrier, has to do with the fact that as physicians we're paid to do something, and doing something may be excessive, and that's how physicians are reimbursed. Now, I'm not saying this happens in every situation. It does not. And some interventions may appear radical, but the purpose is, relief of symptoms. So I think there needs to be an educational program about appropriately assessing individuals. And age is only a marker because they're healthy 90-year-olds that should have aggressive care, and unhealthy 70-year-olds who desperately need palliative care. I think if there was a mechanism to determine the extent of the problem, so to measure, analyze cases that maybe meet the criteria, and then convince the various factions that this indeed is a real problem, and then what are the potential remedies.
Ron?
This is a different type of elder abuse than I'd considered in the past, and I think it's an important type, probably a minority type, but nonetheless something that's going to be faced by more and more of the population proportionally as we age, unless all our healthcare dollars go away, and then we won't have to worry about it. There won't be any extraordinary care. But having served on the palliative care group, and seeing our lawyers from the last session, the idea of a legal remedy in this case I think is particularly strong. At our center, if the advance directive states one thing and the family states another, and you have an ethical consult and it goes to legal, legal always says do everything. Oh, that is, it doesn't matter about the advance directive, it doesn't matter about anything. And there is no culpability for that, there's no prosecution for that. And that is a gut response. And until that changes, until the appeal has another potential answer other than do everything if the family wants you to do everything, my God, particularly if it's a minority candidate or an underinsured candidate, then that abuse will continue. And so the
Can I ask a
legal-
question about that? I'm sorry. Oh, wait.
Sorry, Carmen's next, and then Terry.
So my focus would be on cognitively impaired individuals who are the most vulnerable, can't advocate for themselves. Think about somebody that's sent home from an emergency room in a questionable situation. That may be a setup for abuse. To send somebody home and not provide palliative care will be a setup for abuse. I've seen so many family members try to take care of somebody and been unable to do it. So I think prevention is increased attention to case management, particularly for demented individuals, to make sure that the transitions of care are good.
Terry? Sorry. Next.
Well, I think this whole issue is huge. And it starts with, in some cases, actually the advanced directives in terms of, one area of prevention is making sure that people have paid attention to the advanced directives. And, we know about when that was a provision in the Affordable Health Care Act, and then, it was deemed death panels, et cetera. But that was an attempt actually to make sure that family members did this with loved ones in an informed way. And the diminished capacity just complicates that whole endeavor. But it really is a huge issue. And I was caretaker for my parents the years that they died, slowly and horrifically, and with way too much medical intervention in spite of us trying to do all kinds of things ahead of time to prevent that. And so it is very complicated. And the other thing I think that we need more of is gerontology case managers, advanced practice nurses, clinical nurse specialists who really can get in there and case manage these cases. And so often it does need the nursing care piece because there's a lot of physical care that goes with it also in those case management kinds of things. And I don't think we do enough elder abuse training of those individuals. We don't use those individuals enough or have the capability of using them. But I know at Hopkins it is a huge issue in terms of, how much medical care happens at the end. And although we have really good palliative care physicians now, it's one more physician at the end. And, it really is a huge issue. And I think in terms of prevention, it's one that has enormous healthcare cost ramifications also.
I am of like mind with my colleague from the other university in my state about this issue, almost rabid. I would say that one of the issues that we have encountered, and as you know, I do a lot of work in guardianship as well, has been the issue of the reticence of the guardians, particularly the public guardians who have the poorest, most vulnerable individuals, to be able to make an end-of-life decision. And those people languish forever in hospitals with no one knowing what to do. So this is just a sort of unheard, the sort of unbefriended folks who really have great issues here. The other piece I would want to comment is, where to jump in on this one, not only with advanced directives, which have had mixed success, actually, with implementation starting back in the 90s in the Patient Self-Determination Act and no funding for that. But where I would say is also one way to get at surrogacy is not just with guardianship, which is the last resort, but one way to get at how to assist, enable, help surrogates, because then we avoid those awful issues. Any of us have sat on ethics committees for hospitals of, well, okay, we'll try to convince the family, we'll try to talk, we'll have a meeting. And you're right, Ron, when it comes down to risk management, they're all over, pack it on.
One of the things that I have not heard people discuss case managers, end-of-life managers, and the like, comes from my own bias as a family doctor, where in many of our settings, it's the family physician who mediates with the family and does grief counseling with the families to try to preempt some of this unrealistic behaviors, so that I guess my question is, in the communities in which you're familiar, is there a role for a primary care doctor to be adequately trained to meet with families, to do grief counseling and conflict resolution? Yes, she says. Does it happen?
I would agree, Mark. What's happening, at least in our community, and I suspect in most communities in the U.S., is the advent of hospitalists who typically have no history with these individuals, are usually new graduates from our training programs. and I mean, don't have the experience or necessarily the education to deal with these really complex issues. One other comment I would make, I think sometimes our language gets us in trouble. So anything that smacks of withdrawal immediately is a flashpoint. And I think what we want to do is actually talk about aggressive care, but appropriate care. Palliative care can be very aggressive and should be to relieve symptoms. And somehow if we can reframe it and educate people, educate families, I think there's some hope.
A comment, and thinking about the questions, now I'll try to help you with staying in the lines here. So when you think about potential strategies for elder abuse prevention, one of the things in New York State is there's mandatory child abuse education for relicensure, for licensure and relicensure. There is not mandatory elder abuse content, but child abuse content. So if you were to take a look at these questions 3 in a row and say, well, and I don't know if there are data to suggest that because you had that child abuse training, you did a better job with child abuse detection. But you could say that there would be even institutional or state effort for mandatory education. You could implement that, and in fact, you could probably build an evidence base that places that had that had either better referral or prevention. So I could see that as something that, and regardless of discipline, that if there were some content that was necessary. I don't know how well we do on state boards across our various disciplines on content related to mistreatment. And when you think about prevention, we generally believe that education helps with prevention. But that's on the clinician side.
Mhm. So within institutions, hospitals, nursing homes, long-term care facilities, what is in place now to promote prevention of elder abuse? And if it isn't, what is going to be needed?
This takes us in a slightly different direction. I feel like the most vulnerable elders that you were speaking of are really an important population that we can't lose sight of. But there's an opportunity with the Affordable Care Act and the focus on prevention to think about that welcome to Medicare visit as a place where we could begin doing more, I can't remember if it's upstream or downstream now, but earlier identification and prevention. And I'm noticing that as we try to implement that in Kaiser Permanente, that we're looking at a lot of ways for some of the reasons that you mentioned, that there are so many things that we're asking physicians and nurses to do. Can we use a team approach to really bring in some of the other care providers? And that welcome to Medicare visit, which is supposed to be focused entirely on prevention. We certainly talk about falls, we talk about incontinence. There is no reason not to start identifying some of the risk factors that we heard about yesterday: social support, isolation, prior history of abuse or trauma or depression. And I think that's a very practical place that we could actually move forward and make a dent in the next 3 to 4 years as the Affordable Care Act is really being implemented and those well visits for elders is getting shaped.
Right here.
Yeah, I actually would agree with that. I also would probably add that I think it's important from an educational standpoint to not just have obviously the clinician, but to have that front office receptionist, to have the medical assistant, because those are the people that are coming, they're the front line, and that's the first contact to which that elder patient is coming in contact with. And there can just be a lot of observational opportunities at that point that be conveyed to then the provider from the backside.
And I think when I think about provider, I think a lot about health educators and getting the input from other members of the team, but not necessarily asking a receptionist to be responsible for doing the inquiry
Right, but just
about
to
very
communicate
sensitive
it.
issues. I think it's important.
There's a light on over there. Was there a comment there, Pam?
I think one of the things that I would suggest is that also in medical practice now and in hospital care, and it's moving more and more into assisted, long-term care is the idea of medical records. And so there's options to integrate, prompts to do, the questioning and setting up the format on admission to perhaps, facilitate that. I think and make it easier to actually do it, document it, and then be alert so that we prevent the abuse that you were talking about at end of life.
I just have a question. Excuse me. As we've talked about or mentioned different provider types in terms of intervention, has anyone thought through pharmacists and the role that pharmacists could play? Because they weren't in anyone's list today as we were talking about different, other than, polypharmacy came up, but I still have this warm feeling about the hometown pharmacist and wonder if they can help.
You know, a lot of our pharmacists work with patients with chronic conditions. And one of the things that we've encouraged them to do is to ask, this is a kind of question about abuse, but is anyone preventing you from accessing your medications, coming in for your doctor's office visits, or using your medications? As an entree point for trying to understand why it looks like they're poorly controlled with their chronic medical condition. So a pharmacist who feels comfortable, not all pharmacists feel comfortable moving a little bit more laterally in their work. And nurses, chronic care nurses, are expert at this because they have the training and confidence. So I think broadening who we think about on the team is really a good idea.
Yeah, it is about multidisciplinary interprofessional teams. And at CMS, looking at one of the main initiatives we have, the Partnership to Improve Dementia Care in Nursing Facilities, one of the aspects that we do look at is abusive situations, and we look at the abusive situation in terms of antipsychotics with the pharmacist, the resident, and the physician on staff. And we have been looking at physicians and what they do, and what we're finding is a lot of it's the education of the physician, looking at care-based plans and care coordination. But not only that, there's a lot of fear in dealing with abusive situations. I'm talking polypharm situations at this point, which is it can be a very large abusive situation in that facility. But we have looked at the physician-pharmacist relationship. And I don't know if you can say it's siloed, because I don't know if that's the right word, or it's a turf war. We hear that too a lot. But there's a lot of fear looking at abusive situations of any type in different interprofessional settings.
Can I comment on that?
Go.
So I'm dean of an interprofessional school with 6 disciplines. One of them is pharmacy, one of them is nursing, physician assistant, speech pathology, language, audiology, counseling, interprofessional. So the goal across is to inject the IPEC competencies, and certainly to think about geriatric competencies at the same time. This is very much on the radar of practicing pharmacists, and in conversation with the Minute clinics, the Walgreens clinics, the way in which those databases, they saw 9 million patient visits over the past 5 years. And they're moving from just, you have a little conjunctivitis into, let me help you manage your diabetes. So I think we can expect to see a lot of exciting partnerships, and it's a great point to interject family health.
Jim, and then Ron.
I received funding from a wealthy donor whose mother had been over-medicated to set up a program on polypharmacy, which has allowed me to hire a PharmD, and we have a fellowship in polypharmacy. It's very difficult to really reduce some of these medications in the environment we're in. I've frequently been told by some of our subspecialist colleagues, do not tamper with the diabetic medications. You manage the rest. But yet it's a problem that we have to address. People are really being hurt. Anytime you get above 5 medications, the probability of a significant drug interaction is really high. So, we just have to wrestle with it, and we have to bring pharmacists, PharmDs into the fold. And my hope is with the advent of a patient-centered medical home that we'll work as colleagues. It'll be a very egalitarian type setting, and it can't come soon enough for me.
Ron, did you want to make a comment?
You can, I'll go after Tim.
I just briefly, all of the initiatives on interprofessional education. Terry's comment reminded me of that, and I think there's an IOM committee that's being held right now, or that's in session right now. That certainly all of the forms of abuse would be terrific topics for those interprofessional education. There's more funding of that now through the Mays Foundation, and so I think that that's a way we can get this issue into some other places.
A couple of things. I want to stress again the difference between elder abuse or mistreatment in community residing adults, or cognitively intact community residing adults, and cognitively unintact adults. And then also, if we're going to talk, none of the stuff we've been talking about for the last 5 minutes is prevention. It's really intervention or secondary intervention. Right. But the Mark Lack's data, which I'm astounded every time doesn't change the way everything happens. It's really not staff member abuse and even physician abuse, even if we're having psychotic restraint or pharmacological restraint at inappropriate levels. That's 1/100th to 1,000th. He gave 2-week data that was 10 times higher than our year data. I mean, if you want to stop elder abuse in institutional settings, if you want to prevent it, then you prevent resident-on-resident abuse, which is environmental and staffing ratio interventions. You in a juvie hall, you don't put kids in situations where they can bully, beat up, and terrorize other kids. You have staffing, you have environmental interventions. That is what education is worthless if you're not educating the demented individual who is assaulting everybody else because of frontal disinhibition. And guess what? You can't educate them by definition. So the preventive intervention of nursing home and facility abuse, if you want to get 99.8% of it, it's environmental and staffing ratios. And that's sort of obvious. It should be obvious from Mark's data. But the thing that concerns me talking about prevention for the community residing abuse is it's so far ahead of the horse. What type of violence are you talking about? Are you talking about emotional violence that's an interaction pattern between two adults that's been going on for the past 35 years? Violence as a communication style? Because if you're going to do that, you have to prevent it, I don't know, before they get married, right? Are you talking about physical violence that started among adult children in sort of the domestic violence context? You know, it's really, we don't know very well what the risk factors are, and preventive intervention is contingent at the secondary level upon risk factors at the primary level before you even see them. But that's so far ahead of where we are in terms of our knowledge base that it concerns me that that's the first question. Well, what I would suggest is starting with tertiary and secondary prevention, and you and I were talking about this outside. Who is the person or what type of people see every single older adult in the community? It's not the priest, it's not the banker, it's the healthcare provider, the pharmacist, the primary care doc, now I've learned the dentist. Now, so these are the people who have the greatest contact, and also data show the greatest placebo effect in my field of clinical psychology, which is the most powerful effect. For most therapists are incompetent and never study what effective treatments are, but yet they still have good outcomes. That's because of the placebo effect. And what I mean by that is, if the patient thinks you can help them, then they're more likely to do what you tell them to do. And patients are far more likely to trust and follow healthcare providers' advice than priests, than bankers, than friends, and everywhere else. So that person is in a tremendously persuasive position of power. So they have the trust, they have the influence, and they have the contact. There's no other person other than a healthcare provider that has all of that. But they can't do anything unless they first assess, and that's where the screening comes in. And unless you, because we're talking about tertiary and secondary prevention, primary prevention we can't talk about yet. It's absolutely inappropriate, I think, at this stage, beyond education, beyond telling people there's a big problem and this isn't okay and it's not. but we can talk about secondary and tertiary for the people it's already, and I think your work and Scott's work and your work is where we need to put our eggs for the community residing unimpaired or less impaired individuals. The fact that we haven't changed things in nursing homes despite Mark's data is just, I can't even comment on that. I don't know how we're not having that conversation.
Well, I think, at least in my milieu, that's just a function of costing and personnel, that you don't have adequately trained individuals or inadequate in-service education that is not done at a frequent enough level, that staff aren't monitored on a regular level to assure adherence to guidelines that are established within an institution. But you could go back one step further, though, Ron, in terms of at the primary level. We have heard some discussion over the last few days about education that takes place at the level of young adults, children, and the like. And I'm not sure that we necessarily adequately go for that money as actively as we could. Go for it meaning have the programming. I don't know what your television spots show here, but in my part of the world, the television spots are almost invariably somebody saying something or doing something harmful to an older person, either on TV or in a newspaper ad. And I often wonder, why is it that there isn't a grandchild there observing and having somebody have a discussion with that grandchild about what's going on? Because it's got to start at a level that maybe there's potential to break the cycle, at least at certain socio-demographic levels of our society.
Can I say something to that, since this is somewhat social and I don't know if I'm going off, but just food for thought as I was listening to Ron speak. I think the person fit environment is a really good thing to focus on when we're talking about individuals in institutionalized settings, because clearly, as Lawton demonstrated in his research, the environment has a huge effect on the individual. However, we need to think about, when we're talking about institutionalized settings, we need to think about or take into account regulations and what that does to the individual. Are we over-regulating and basically increasing adverse risk environments, increasing that upside risk? And does that create or put at a disadvantage the resident and put at a disadvantage the workforce, the direct care worker, the licensed personnel that work within that facility? Are we trying to create or break down so many barriers that we're actually causing or doing more harm than good? And I don't know if that's going off bandwagon, but that is just something that came to mind when Ron was speaking.
I like that. Could you put it in a framework that would hit 1, 2, or 3?
Oh yeah, let me try. Okay, steps to implement strategies. I guess it would be just speaking from the CMS perspective, because since we have so much guidance, we have F tags that look over or review basically different interventions within, I'm talking about nursing facility settings right now, to basically decrease risk for the resident. I guess I could look at number 2 and say, are we, as an action step to decrease risk, increasing more risk by implementing strategies as greater regulation or expanded regulations, expanded F tags? Are we actually causing more harm than good? The intention's not to cause harm, but are we actually causing more harm than good by basically creating greater regulation within that institutionalized care setting?
A couple of things in terms of prevention, and also has to do with the evidence base. I think that one of the things that's really clear is, and from all of the violence research, is that we definitely have increased risk for both perpetration and victimization when you have experienced other violent events, either as perpetrator or as victim. When you have been the perpetrator, when you have been victimized. so that one of the things that makes a difference is whether or not the perpetrator of elder abuse is a traumatized individual, which you can educate them to death about how you shouldn't hit. That's not their issue. You know, it's that trauma. So one of the primary preventions for elder abuse is addressing traumatized individuals, providing the appropriate trauma care for traumatized individuals, be they in juvenile delinquency, because those are the kids that go on to abuse elders. And when they're being punished through our correctional system versus in any way, shape, or form healed. So it's not that I'm saying, don't hold people accountable. I'm just saying, and our veterans come back, and our Vietnam vets now are, many of them that had serious PTSD problems are both victims and perpetrators of elder abuse. And that's one of the things that the VA is dealing with. So, that's got to be part of the picture. Education alone does not prevent people from being violent. And then the other piece of it is in terms of when we're looking at, whether we call it communication styles, but I think it's more deep than that. And we have so much of elder abuse being violent couples, getting older, and, back and forth kinds of things, but they're actually using violence. And that's a different group. And talking to them about better communication is not going to address those long-term violent patterns that sometimes even get worse when they're elderly. And then there's the whole caregiver stress, which is part of prevention in terms of when when an elderly person is diagnosed, for instance, with Alzheimer's, where is the intervention, an actual intervention for that caregiver who's going to be giving more and more care, more and more stressful care, more and more risk that person's going to behave aggressively as the cognitive problems continue. So, those are all prevention strategies. So I think in some ways, we don't know enough about prevention, but we can build on what we do know about prevention of other forms of violence.
Carmen?
So when the IOM report came out on the decreased shortage of healthcare professionals for older patients, the American Board of Medical Specialties put out a paper saying, you know what, that's right, we're going to need to sometime introduce geriatric topics in all the specialty boards. And so, geriatrics, gerontology is so broad, but what if the IOM, what if other groups, American Geriatric Societies, CMS came out saying that everyone has to have some training in elder mistreatment, just recognizing financial, physical, etc. And then a lot of solutions, in the emergency room in Louisville versus in South Carolina versus here versus in Texas, you're going to have maybe a different solution, but at least if you begin to recognize who's at risk, that would be a good thing. And so it's one thing to say you need a whole geriatrics curriculum. It's the other thing to say is everybody ought to have training about elder abuse. That's true for child abuse. Nobody graduates from medical school without understanding how to recognize the signs of child abuse. And we need to just call for that, 1 hour in people's curriculum, and not just doctors, but other health professionals.
And as an addendum, if I could throw that in, that the places where that has worked the best is if within each institution you identify a champion who is the person who is both the resource and the mover for that particular part of the curriculum. And that person can be a real irritant, but the message gets through.
And then that's how you do it, and then you evaluate it. You put one question on the national boards. You know, I did when I was, I was working for the national board. You put one question in people's exams, and they know even one question is going to be there. They'll study.
But a lot of the curriculum for, like, if we're talking people like direct care workers at this point, creating some type of curriculum to make them advanced, like an advanced aid such as PHI is suggesting right now in the Elder Care Workforce Alliance, a lot of that is a state-based decision.
Right.
And you have to go state by state because every curriculum is different per state. Or, the age training, age-specific training, sorry to interrupt you, Terry, is different per state, where you have states like Louisiana that may be doing a little bit more, and New York that hasn't because they have to go through all the hoops or whatnot. But advanced aids, advanced anything in the workforce is so needed. And I would suggest CMS look at that too. So.
And I couldn't agree more. It's so important. I want to go back to the notion of childhood trauma and say that in our last study, we used the childhood trauma questionnaire by David Bernstein and found that not only for the elderly, but for their dyadic caregivers, there was a relationship between a positive childhood trauma questionnaire score and the outcome of neglect and abuse. And so I think no matter what measure you choose, this idea that we follow this, because you could prevent, if you knew somebody had a positive childhood trauma questionnaire and they were not yet exhibiting any evidence of elder mistreatment, you could do the prevention that I think I've heard people talk about.
I think my study on proclivity to elder abuse got similar findings, where people who report that they were abused as a child. Turns out grown up being report on more proclivity to abuse. But then I want to see if there's the situation in other places, because in Hong Kong, what we observe is there are polyvictimization within a family. So it is not like I was abused as a child and I grown up like elder abuser. So I have in the same family at the same time, I have wife abuse, I have child abuse, I have elder abuse co-occurring. So would it make sense, if we do the prevention for family as a whole, rather than just on the individual level?
That violence as a lifestyle, I said communication style, but as an interaction style is certainly a recurring theme. I got up and said prevention is impossible because we don't know anything, but we do know a little bit, so now I'm going to suggest the opposite thing. We talked about this the other day. Community integration, meaning community contacts, is one area that looks like, and we call it social support. Really, I call it being touched by the community or touching the community in some way, getting the hell out of the house. We know that helps older adults after disaster. That was nicely demonstrated in a couple of studies. We think that it is a major risk factor for elder abuse. We predict it would be a risk if you don't have it, a protective factor if you do have it, for dealing with the effects of elder abuse. It most certainly would be an intervention factor for breaking a competed cycle of abuse if people were educated to screen for it. But that is one thing. It seems to have multiple benefits. So even if it doesn't work for one area very well and it doesn't work for another, it can help with resiliency after disaster. It can help with poverty prevention, nutritional deficits, and now elder abuse and its outcomes. So I would suggest for the best prevention strategy that we could think of that would get multiple bang for the buck is this community contacts and community connection for older adults. Transportation has been identified by the WHO as a major problem for older adults. I think that's going to be the intersection point between exacerbations in elder mistreatment and older adult increased population sizes. Where there's lacking transportation, where the doorman doesn't see him every day, where the baker doesn't see him, the pharmacist, the doctor, whomever, where the person is groomed to be isolated, you're going to have more family violence. You're also going to have more other types of violence. But it's all going to happen together and continue in that little isolated kernel.
I'm going to suggest another possible model that that is currently used in the UK under the Princess Royal Trust. About 5 years ago, there was a project designed to create a database of family caregivers. Effectively, as I understand it, it was a you'll like it, a telephone survey identified as many caregivers as they could get, identified the names of the physicians involved, and a database was supplied to each general practitioner in Britain. And the expectation was that this physician was supposed to have a particular flag by which something was put onto the chart to identify that this was a caregiver. That was part one of the exercise. Part two of the exercise, which is, I gather, now completed but in its evaluation phase, is that they paid the physicians to participate in X hundred hours of continuing professional development on issues pertaining to family function, caregiving, and the like. And the study is designed to monitor whether the intervention of making sure that that physicians are adequately aware of who is caregivers and is aware of a reasonable number of the caregiver stresses, worries, concerns, liabilities, etc., that there would be the potential for behavioral change on the part of the general practitioners. As I say, I don't have the data on this yet. The preliminary, it is on the web. It's easy to find. The preliminary information sounds encouraging. And to me, again, from a very biased perspective as a family doctor, is a much more holistic way of looking at the patient and caregiver in the context of who I'm seeing in my practice. And if I'm seeing that somebody is a caregiver, then I'm going to have a care receiver. I'm going to have a sufficient number of inquiries that are going to be made to that patient on any particular visit that revolve around some of the themes that we've talked about today.
Could I jump in? I have a primary prevention idea and a circuitous answer. So I have to start over here and come back to primary care. When Dan Reingold was talking earlier and he was irritated because of how we characterize nursing home placement, and I understand the nature of his concern. I mean, that the reason that that's an effective threat, I'll send you to the nursing home, is because we've managed to provide really awful nursing home care and really need to look to people like Dan and others to provide quality care, and I believe it's possible. But one of my concerns about the community versus nursing home construct is that we should never set up older people and their families to see a nursing home admission as the failed outcome of community services, but another setting with another type of care, because I think that this all tracks back and connects to neglect in some respects, that people make a false assumption that I'd rather stay here at home, whether I'm the older person or the caregiver, than go there. And the false assumption is that my care here is better. They only know how bad care could be at the nursing home based on sort of the history of what we've done, and it's actually, I think, not current, but a false assumption that care in the community is better. Tracking to primary prevention, I think this at some point rests upon a very fractured long-term care system in this country and lack of good information to older people and families and their caregivers about what their options are. So if we're really going to tackle neglect and possibly impact direct outright abuse, one of the things that we're working on through our work with CMS on Aging and Disability Resource Centers is options counseling, identifying the core competencies of providing options counseling to older people so they know what their options are for staying in the community. And one of the things that we will build into those competencies is training about elder abuse so that the people doing the screening, that also should be embedded into conversations we have with caregivers about options so that they never get to a position where they feel like that this is the best outcome, there aren't any other choices, and they simply can broaden the conversation. And part of that conversation has to talk about quality, that this is the quality that we should aim for their lives as caregivers, but also for their loved ones. So that's circuitous, but I think basic education is primary intervention.
I would put a caveat to that, again, going back to a study that I mentioned either yesterday, I guess it was only yesterday, in looking at caregivers' readiness to accept recommendations. You can give caregivers as much information as we think is important. But if they have not gone through the necessary steps of adjustment, grieving, and in many cases, going through a narrative of what the illness experience has meant to them, they're not ready to say, even though they know that the end point is going to be the nursing home, they need a lot of time and hand-holding to get them along that trajectory to say, okay, I've done what I can, and a nursing home is okay. And as well within certain communities, and again, this is American literature, not Canadian, faith groups play a very strong role in discouraging individuals from having their relatives go into nursing homes, because that's viewed as failure, that your role is to keep your relative at home and do everything absolutely possible. So there's a lot that mitigates against. You can give them the trajectory, you can give them the plans, you can give them the ideas, but it's only when they have worked through each of these hurdles are they going to say, okay, yeah, the nursing home really does make the most sense.
Tried to advocate for more nursing home admissions, only that a successful placement in the community involves a community of people, not just that one caregiver, and that you have to have a plan that's a little broader.
I have both a social work and a public health background, and as I'm sitting here listening to this, I'm not that familiar with the field of the elderly and elder abuse, but as I'm sitting here listening, it sounds like there are so many things that are going on, and there's a need for comprehensive services and strategies, and it makes me think about the case management model. It seems that the physician cannot, or the healthcare provider cannot do everything, and it seems like there's a need for some type of case management model that has been used in other fields and has been found to be successful. So, for example, HIV and substance abuse, where there's someone who can help guide the family through the process that you described in terms of understanding what are the problems, is there trauma that needs to be dealt with, is there a need for respite care, is there a need for long-term care. So it sounds like there's really a need to help the family kind of look at what the different options are and make some choices. And so maybe it's a matter of healthcare providers somehow linking with case managers who can help provide comprehensive services to address the multiple needs of these families.
One problem with that is you're not going to see a lot of it, and if we don't, we need to get to that step. I think that would be great if we could identify it, see it, and then say, okay, now what do we do with it? But unless we have the contacts, unless there's, I mean, the Sentinel approach didn't really work well as an assessment strategy, but if everybody becomes a Sentinel, then it does. And it's that what we did with child abuse and now domestic violence through tremendous public awareness has helped. I'm in South Carolina. I can tell you it hasn't helped much. We're either the first or the second state in domestic violence murders. And I think the rurality of our state has a lot to do with it. When you're disconnected, it's easier to get away with it. And it's also easier to have that interactive style. And violence as an interactive style in this society is tremendously high. Our homicide rate is consistent with third world countries. We blow the doors off of Ireland, Israel, other countries that you think have a lot of bombings. We are a very violent country. And whatever facilitates violence will facilitate elder abuse and domestic violence. I don't really separate the two because most elder abuse happens in the context of adults against adults in the same family. One thing we do know is that observation diminishes aggressive behavior. And so when you're connected to your community, when you're out, when somebody sees the black eye, when somebody sees the injury, when somebody sees the crying, when somebody hears this, but our increasingly nuclear family system is causing, forced isolation of our community residing adults. And I thought, isn't this great? The internet can deliver groceries to your door. Now there's even fewer reasons. My grandmother very rarely leaves now that she's discovered Amazon. And, I try and tell her it's good for you to get out, but she goes, "But this is so convenient." It's like, well, who sees you? She never leaves the house now. She's on Skype instead of visiting. She's on Amazon instead of going to the store. So I'm worried about her for health reasons, but I mean, What if there was an abuse potential? We would never know. So the way community facilitation and connection, I think, is going to be key to get to that step of case management. We need to.
I'd like to interject the comment that we heard yesterday about technology, smart homes, the appropriate use of apps, computers, robots. I was on a NIH review for robotics and home care for those with disability. It was fascinating, and so I think that the opportunity for us to bring that into the conversation in a way that is not overstepping bounds when it comes to privacy, but at the same time helping people we watch for common strategies. We have a lot of interesting things coming up with robots. Yeah.
One of the things that keeps coming up is the idea that we need sort of a continuum of care to do this. And I think sometimes we look at acute care versus, sort of what they're doing in the community, what you're doing in your home. And the other option is going into an institution. And I think there should be a lot of variation in between, a lot of, respite care, a lot of daycare, a lot of volunteerism, which is at the heart of our citizenship in the United States. I think that, we know that incest, sexual abuse, domestic abuse is a phenomenon of secrets. And the more that you can, put people into touch with each other. And so I think that continuum of care, offering that, getting more people involved in the lives of others and away from sitting in front of their computer and in their home and isolated, is an important feature. And I think that going back to sort of theoretical frameworks, I think we need to think of it always as a multi-system approach towards doing anything here. There's no one thing that we can do. I think we need to, use the environment. We need to use, everything that we know to have an impact.
We are, 1 minute after the break?
We have a very fruitful discussion. And from what I heard, if I am to summarize what we have said here, I think we've said a lot about choice and expectation management, if I put it correctly. So we start with a case of aggressive care at end of life, and from that we look at different steps. The first thing is this has to do with choice, that we need to advocate the use of advanced directives, and then guardianship. And so this also applies to people with cognitive impairment, if I put it correctly. And then for prevention effort, we are looking at, we look a little bit on detection. We look a little bit on the tertiary prevention. That is to use a multidisciplinary approach, informing different professionals, pharmacists, for example. Somebody mentioned pharmacists. And then, having them to ask about questions they feel like, say, is there anyone prevent you from using your medicine, or is there anyone using your medicines? So that may be an important way where we could do the early intervention. And then for prevention effort, we talk about curriculum change, and we talk about interdisciplinary training, training of different, using a team approach that connect different care providers apart from nurses and physicians. And then an important element raised by Ron would be the use of community integration. That is, apart from preventing elder abuse, that actually have multiple benefits. And if I get it right, all those benefits actually prevent elder abuse. And then we also need to talk about prevention. We also need to look at victims of family violence, because lots of those victims, well, who are traumatized, they turns out being abusers themselves. So early interventions, taking care of victims of domestic violence in the long run would help us prevent elder abuse. So, and then we need to this is also about choice and decisions. Between community care and nursing home care, there is a huge continuum. And we need to help family caregivers and older persons themselves to manage their expectations and to change the ideas that nursing home is a very bad place to go to, and that putting your older family members to nursing home means that you have failed as family caregiver. So that perception need to be changed. And did I miss anything? I'll try to organize that better when I report back.
Can I add something to that last? Because I really believe in this world we need probably fewer nursing home beds than more. I guess the way I would amend that is to say we need to focus on quality in nursing homes so people feel like that this is an acceptable choice for them, because that's currently what's driving some of the decisions to not go there. And we're not there yet in this country. We are with some, but we're not there. And if it's seen as an acceptable choice, it could relieve some of the pressure. But I believe that we can do more and more and serve people with higher levels of community and higher levels of acuity in the community than ever before. So I still think we're overbedded in this country.
I think one thing to add on nursing homes is that the data strongly show that it's
Resident
residents who are the perpetrators,
Okay.
not staff, not family.
Okay. Yes, did I mention that about the cognitively intact and cognitively impaired individuals, the difference? I mentioned that, right? Okay. I just got through.
I would add from all of my pages of scribbling that part of the multi-level, multidisciplinary training also included non-clinical providers in terms of administrative staff, and also the connection between the use of technology from EMRs to be able to provide better documentation that might include heightened sensitivity for screening and assessment, all the way to the use of apps and robotics in terms of whether that provides a more effective sentinel approach in terms of community-based care.
And I want
It's
to come back to
EMR,
just recommending that we include the some kind of inquiry about abuse risk factors in the Welcome to Medicare visit as part of
Oh,
prevention.
yes, the Medicare visit.